Good day, everyone. Thank you for joining this first webinar of the new year 2022. Happy New Year to all of you, and we hope you are keeping well and healthy wherever you are. My name is Mary-Christine Collette. I'm education specialist promoting the training activities of the Swiss DolorClast Academy, which is the educational platform offering programs related to shockwave therapy, but also combination therapies with the guided DolorClast therapy concept. We have the pleasure to welcome today two of our GDT specialists who are based in Germany. So we have today Peter Stiller and Alexander Ablas, who are specialists in sports medicine, but I don't give you too many details so that they can introduce themselves directly in the introduction of the presentation. Before starting this webinar, just a few technical points. As you can see on your screen, you have a chat and Q&A icons. Please feel free to use them to ask your questions, and we'll be able to answer them during the session. So that was for the introduction. So Alex and Peter, off you go. The floor is yours. And thank you for being with us.
A pleasure. So, do you think we can start?
Yes, you can start when you are ready.
Okay, do you see our display already?
I can see your display, but not in the,
Is it, now it should have started. Okay, because we have so many different participants today, so I have to say good morning, good evening, good afternoon to everybody. We are very happy that we have so many participants for this shockwave therapy webinar today. I just introduced ourselves very short. My name is Peter Stiller, and I'm together with my friend Alexander Ablas. We are doing shockwaves for years and years now. I think it is very important that we work together very well from the first day on, I would say. And I'm a specialist in general medicine. He's one of the best physiotherapists that I've ever seen. And we have our own practice here, and we've done a lot of shockwave also in professional sports, because I've been team doctor of FC Augsburg. It's the first league in Germany, the first Bundesliga, and Alex was the head of the youth academy of FC Augsburg. He was, I would say, the man who brought the youth academy to the very good standard that it has today in Germany. And we will show you today some theory for the first part. That's the first part, but it's a short part of, I think, 30 to 35 of maximum 40 minutes. Then we will show you some case reports in combination with live treatment. And after this is the biggest part, I think, and then we'll have a question and answer part where you can interact all together. So after our introduction, that is not so important. The most important introduction for the theory, so means the science behind shockwave, we have to introduce Professor Christoph Smets. I think everybody who's doing the shockwave therapy with the DolorClast has heard his name before. He is the head of the neuroanatomy department of the University of Munich, and he is one of the most well-known and most famous scientists in the world for shockwave therapy. I'm introducing him because what you hear about evidence-based medicine with shockwave is nearly all from Professor Christoph Smets. Now we start what we really want to tell you. We start with the GDT, the guided DolorClast therapy. It has 6 steps. Consists of 6 steps that are very important if you see it as a complete program. It means, of course, we all do at the beginning our anamnesis and examination of the patient. Then we have the possibility to use a high power laser, which is perfectly in combination with the new DolorClast radial shockwave. Today we are focusing on this device. but we also have the focused shockwave device, of course, and afterwards rehabilitation and the follow-up examination is for everybody who is working as a doctor, as a therapist, absolutely pretty normal. Just to show you what we mean by GDT, we work with the high power laser at the beginning, and after a short time, maybe of 5 minutes or 1 hour, we do the shockwave therapy with the new DolorClast device. And what it brings us is that we can use much more power, more working power, more working pressure with the shockwave, and so much more energy can get into the tissue and work into the tissue, and so bring us the best results that we can have. This only in short, because as I said, we focus on the new DolorClast device, but I think it's very good if you have seen these slides before. Everybody of you can have our slides. That's no problem with Alex and me. Whatever you want, tell us. We will send them to you afterwards. Okay, this is the new Radial shockwave device. With very important is that it is mobile. You can take it away, and you have the possibility to have 25 hertz. For us, it's we think it's very good because we can be much faster with our treatment. Very big. Oh, yeah. Sorry, it doesn't work. Oh, but for us, a very big advantage in the treatment. First of all, very short, the theory of shockwave therapy as a short repetition. What do we want to achieve by using the DolorClast, by using such a great shockwave device? We want less or no medication anymore, no injections, especially no cortisone injections, no or fewer operations. We are working non-invasive and less risky than other therapies, especially surgery. And we are very high effective. Means we have in all kinds of indications more than 80% of positive results. That's very impressive. The science behind it comes from the Pedro database. It's the physiotherapy database from Australia. It's situated at the University of Sydney, and it's very important that this is physiotherapy as we all know it from, for example, Australia, Norway, England, America. In Germany, it's different because in Germany, physiotherapy is not as big, I would say, than in these countries. We have in Germany orthopedics surgeons, we have orthopedics working conservative, and we have physiotherapists, and that's the difference. That's only for guys who have the same system in their country than we have in Germany. Here's a short list just to show you that most of the studies that were made over the last years and are really high positioned in the Pedro database were done with the Swiss DolorClast. It's 75% of all of them, and they have a very good outcome. That's what we want to show. I show you the 3 most important conclusions of all the work that Professor Smith did on the Pedro database. One is there's no general advantage for the focused shockwave over the radial shockwave device, because the results can be completely the same or even better. So it's not always the focus is the better one. This is really a wrong conclusion of the last 20 years. And there's no basis for the compilation that the focused shockwave is high energy and the radial shockwave is low energy. That's wrong, because we can also get the same high energy level with the radial shockwave device than with the focused shockwave device. And what I said before, 75% of all RCTs that were made in the Pedro database were made about the shockwave device in the Pedro database were done with the DolorClast. The technology behind it, this is the old handpiece of the radial shockwave device of the DolorClast. It's a ballistic generation, means that compressed air is accelerated accelerates a projectile which strikes to the applicator. We have different applicators, you all know that. And then from the beginning of the applicator, there is the energy is converted into a wave, a shock wave that comes in a radial way, different to the focused, of course. You can see it here on the right side with the compression phase with the first wave. Then the picture below shows then the cavitation bubbles and the secondary shock waves that bring the cavitation bubbles to collapse. And this is the second energy wave that comes up when you use the DolorClast Shockwave device. This is the new handpiece. You see there's not so much difference in the handpiece itself, but you have the buttons for the pressure to increase the pressure or to decrease the pressure directly at the handpiece, which is a big advantage when you're treating the patient. And that this is still a conclusion, still a repetition. You know, we have a positive energy first phase, and then a second in a negative energy, negative pressure phase, which is combined with the cavitation bubbles. When you go into the negative phase of the shock wave, then we see the cavitation bubbles. But we are discussing this a little bit later. First, we want to show you what is absolutely unique in radial shockwave devices. It's the radial pressure when you go up with the frequency. The DolorClast device is the only device that can stand the energy and the pressure up to 20 and now 25 bar. As you can see it here in the diagram, all the other competitors are going down from the beginning on. If the frequency goes on and the frequency increases, especially after 15 hertz, there's nearly no energy left. And this is completely different with the DolorClast, and that's the most important advantage that we have using this kind of shockwave device. Now we have to explain a little bit the new programs and modes, but really in short, because I think everybody should collect his own experiences with it. We have a smart protocol. That means that you can use it as you want. You can put the pressure higher, you can put the frequency higher, and the impulses too. And then we have some programmed programs that or modes that we want to show you. For example, for tendinopathy or for enthesiopathy, it is not really so important to change or to always use these programs. You can do it how you want. We always, for example, work with 25 hertz because we see no sense in using lower frequencies, because we don't have so much time that we can say, okay, we work slower than we could. And as you saw before, the pressure and the energy stays nearly the same if you go up, and so you can work faster. And a lot of patients like the higher frequencies more because it's not so painful. These are the other ones, for example, and how they are pre-programmed. You can just see them here and then make your own experiences. I think for the muscle, for example, it is very important to have, of course, 25 hertz as massage mode. I don't think that we really do a massage with the shockwave device, but they had to call it some the program, give a name to the program, and massage means, okay, this one is really in a higher frequency, that's all. The modes that you see down there under the display are the analgesic, the ramp up, and the burst mode. The analgesic mode only means that you can go lower than 1.0 bar. Normally you only have the lowest level is 1.0 bar. If you go on the analgesic mode, you can use 15 hertz or 25 hertz, and you can go down to 0.9 bar if somebody couldn't stand the 1.0 0 bar. That's all, and it's always programmed on 1000 impulses. The ramp up mode, that's different. The ramp up mode means that you don't have to do something and the bar, the pressure, the working pressure increases fluently. So it means you do 150 impulses and then the device goes up from 2.5, for example, to 2.6. You can see it here in the picture row. After 150 impulses, it goes to 2.7 bar and so on. And the ramp up mode 1 is only that it goes up a maximum 0.5 bar. The ramp up 2 mode increases up to 4.0 bar if you don't stop it before. So this is on your own. It's your choice how you want to work with it. The burst mode means that you can change between 2 frequencies. Sometimes it's really, for example, in a muscle, it can help if you have 2 different frequencies to get for example, a hardened muscle open and relax it better, or some patients are not sure if, for example, 18 hertz, as we have it here in the example, or 20 hertz or even 25 hertz are better. So you can try 2 different frequencies. At burst mode 1, it's a 4-second frequency set on the frequency on the frequency you set. Means, for example, 18 here, or if you want to start with 20, you set it on 20, then it's 4-second 20 hertz, and afterwards 2-second 25 hertz, and then it goes back to 20 hertz. And the burst mode 2 means that the frequency that you set is used until you push the power button. And when you push the power button, it goes up to 25 hertz. And if you lose the power button, it goes back to the frequency you wanted. Everybody, as I said, has to do its own experience on this, but I'm quite sure that this will be a mode that you use sometimes to see if the patient likes the higher frequency more, or even sometimes a little bit slower frequency. We don't need it so often, as I said, but sometimes it's useful and you can try this. As I said, we want to talk about cavitation. This is a study that showed that significant tissue effects are reached with the cavitation bubbles. Means that cavitation is a very important part of the whole shockwave mode of action. And it comes from the negative phase of the shockwave, means the negative pressure phase, I would say, loads the cavitation bubble, and then with the second wave of the shockwaves, the cavitation bubbles implode and leave these, as they say, the jet stream with a lot of energy, which makes a big part of the energy and of the effect of the shockwave therapy. To show you the differences between different handpieces from different devices, we have this picture where you can see, for example, the BTL device with its handpiece when you use 15 hertz and 5 bar. The BTL and Storz device can do 5 bar. Here's the Storz device, and the EMS Evo Blue means our handpiece shows with 15 hertz and 4 bar, it's 1 bar less, much more cavitation. We don't talk about the Symbol device. There's no cavitation at all, but this means, if you see it here in the picture compared, this means that you have much more cavitation, much more energy that comes into the tissue. And I think these pictures are clear. There's nothing to discuss. Here we have the same, where the cavitation bubbles were counted by the computer. And I think this is even more impressive to see how much more cavitation comes from the handpiece of the DolorClast. Now to the molecular and cellular mechanisms of action, how it works, how does shockwave works in the musculoskeletal system. Very important in this is that when you have injured tissue, everything is committed over the C fiber. That means that substance P is released over the C fibers and does different things. On the first, of course, it is painful if there's an injury, but also substance P activates the mast cells and gives histamine free, for example. Substance P has influence on the blood vessels, and this together, this neuropeptide substance P, makes more edema, hyperemia, erythema, and of course pain. It's the so-called neurogenic inflammation, and this is very important because this so-called neurogenic inflammation is what we want to decrease and what we want to get out of the tissue, because then it can heal, as I will show you a few files in the future. To explain how it works, we have to talk about capsaicin. Capsaicin is contained in red chili peppers. You all know if you bite on a chili pepper, if for the first moment it is very hot, it burns, and then if you do this 3 or 4 times, your tongue gets numb. That first it burns, then it gets numb. As I said, as I wrote it here, that's the same with the shockwave device. You do nearly the same. If you put the shockwave on the tissue, you have a release of substance P. So at first it gives you a pain, and then the C nerve fibers become incapable for some time of releasing substance P. The depots are get empty, and then it recovers so that you don't feel the same pain. That's when you work with your patient. Everybody knows that you put the device on it, you see the pain in the face of your patient. You tell them wait for a few seconds, and then it gets better. Here in the summary, less substance P means less pain, means less neurogenic inflammation, and this together with the release of growth factors and the activation of stem cells, which are the 2 most important parts of what shockwaves release and do in the tissue, then you get a combination that brings you real healing. If you can decrease the inflammation and get up the stem cell activation and the growth factors, this is what we call healing. And especially on the nervous system, this is what I want to say at the cavitation again. The nervous system is really not easy to heal and to effect, but cavitation, it depends on the cavitation. Yeah, the more you have cavitation, the better you can work on the nervous system. This is only one file to show you some things in short. So I think this is very good, for example, to print and to show to the patients, and you can explain from the file a lot of things to the patient. I think this is really good to have in your practice. Another point which is good for repetition is that we never use local anesthesia when we use shockwaves, because this, and we have a very big study here from Mr. Rompi, one of the most well-known specialists for shockwave in the world, and they are very clear that you cannot work with local anesthesia because the efficiency of the shockwave is extremely reduced. So never use. It doesn't matter what you hear. There are videos in the internet where they say you have to use local anesthesia. It's only important to always get the highest power in. This is not, I can tell you, these are not videos that are concern the DolorClast, because here it's different. We have much more power in the tissue than other devices, so we don't need local anesthesia at all, and it would work against your treatment if you use it. As a conclusion, what does shockwave therapy do? We have, of course, a reduction of chronic pain. We have a blockade of the neurogenic inflammation, which is extremely important and necessary. The action of mesenchymal stem cells is the next step, and the releasing of growth factors, and so we get the healing, and that the blood circulation is going up is something that everybody knows who works with shockwave, I think. In very short indications, you all know the classics, as I call them, the indications that we all work with nearly every day or every week. The classics like the calcified shoulder or the Achilles tendinopathy, enthesiopathies in your elbow, or the heel spur, or the patella tendon. I don't know if anybody, I think there's nobody who didn't work on these indications when he's doing a Shockwave about 1 or 2 months. Then everybody had these indications in his practice. But it's growing and growing. I think the newer indications or the approved indications that we now work on regularly are, for example, also trigger points. I'll say something about trigger points a few files on. Lymphedema, of course. We have the greater traumatic pain syndrome. We have the lower back pain. This is very interesting because lower back pain we didn't have a study for proving that it works on lower back pain until 2 months ago. There came a big study from China, also from Professor Schmitz, and it says that lower back pain can be perfectly treated with radial shockwave, where we work on the medial tibial stress syndrome. We work on wounds, especially in diabetic wounds at the feet. And so on and so on. And the Schlatter disease, for example, the only indication for children. So you see, there's a really big summary of indications. What I want to show you are indications that are partially off-label, of course, but for me and for Alex, in additional indications that we also work on regularly. All forms of muscle injuries. We really say all forms of muscle injuries because it's from the little hardening to the biggest muscle rupture. It's all kinds of arthritis or osteoarthritis, chronic polyarthritis of the hands. We'll see an example later. All kinds of spine syndrome, means acute or chronic, sacroiliitis, fractures, pseudoarthrosis, of course, bone bruises, bone marrow edema. We are working on osteochondrosis dissecans, tension, headache, migraine. The iliotibial tract syndrome is coming up the last years, I think, very everybody can see that. And the morbus Schlatter means the Osgood Schlatter, and morbus Sever, which is a bone marrow edema in the calcaneus. And we use the shockwave also for people suffering from COVID-19 or from the long COVID because of problems with their lung. I know that normally this is said it's a real contraindication, but we could see that we can have influence on the diaphragm, on the muscles between the ribs, and it works perfectly. They can breathe easier, have less pain, and I can show it from an abstract. This is one from Christoph Schmitz and me. It was a work on a 14-year-old girl suffering from severe COVID infection. And after 9 days of trying with cortisone and all these things to get her breathing better, we used the shockwave just to get the pain from the thorax away and make the diaphragm better. And after 5 days treatment every day, she could breathe properly and get much better. That's why we now use it, or try to use it, for people suffering from a chronic bronchitis. And we have the first case reports that it also works there. You only can use radial shockwave, of course. Never use the focused shockwave, and you have to talk to the patient before and tell him that it normally is a contraindication. But if you try it with the radial shockwave device and you are sensible for the patient giving you the hint that now it gets a little bit painful, then you cannot harm anything. But all the guys we had are now breathing easier. Trigger points is for us very important because it is, I think, an upcoming problem of our of nearly everybody working with mobile phones. A lot of work on the computer. You see here a colleague of us sitting in an airport and working on his mobile. This brings him, I think, about 8 to 10 new very painful trigger points, and we can explain why this is the case. Travell and Simmons have a lot of modified circles where they show how it comes to these very, very bad pain situations in trigger points. So because you get a local hypoxia, the tissue gets under stress. There are sensitizing substances that are given away and bring more pain. Then you have an automatic modulation of the muscle because of the pain, and so it goes on. And if you can see the contracture notes there, everybody knows them. Everybody I think everybody of you can feel them every day when you're working on muscles with your patients, and it is perfectly to use the Shockwave device for this, because what we further know is that myofascial trigger points are or have an biochemical milieu of inflammatory mediators and neuropeptides and cytokines that is nearly the same as you have in enthesiopathies and tendinopathies. And we know that the Shockwave works so perfectly because you're working on the neurogenic inflammation that these tendons have, and the same you have in the trigger points. And that's why it is much easier and much better to work with the DolorClast in the way we do it, for example, or I hope you do it in the past, than all the physiotherapists who are working only with their hands. That's the difference. Here is a little conclusion for this, and yeah, what we can say is trigger points can be treated very efficiently by shockwaves. Here's, as I told you before, the study of the low back pain. I just wanted to show you that there is a study. You all can get it from the internet. I think this is really a game changer, because now we can really show that low back pain can be perfectly treated with shockwaves, and we have got much better results than only taking NSAIDs or cortisone. Very short, what is important for me, it is not only the effect on the pain and the effect on the inflammation, but if you work with tendons, especially after operations and after keeping extremities in a plaster or something. So you have the problem that you lose the gliding of the tendons. This is because lubricin is missing. Lubricin is the gliding stuff that you need in your between your tendon and your tendon skin, and this is only produced by the body if you have movement in this part of the body, if movement in the tendon. If you don't have this, lubricin is going away, and that's why it gets it's like a dry effect that you can feel if you get your fully operated extremity out of the plaster. And the second way to produce lubricin is only shockwave therapy. You can do injections, whatever you want. You will not have real lubricin production. With shockwave, you can reach this. Here, this is the study that explains that high dose shockwave treatment can get more lubricin, get a new lubricin production and more lubricin into the septa. Now we are at the end of the theory part. I always end with this, and I think this is from George Best, one of the best and most known, best known football legends in England. He said, "Pain is temporary, glory is forever." That's exactly what we want to show you with the shockwave. First, it's a little bit of pain, but what we reach and what the results we can show are extraordinary and very, very good for our patients, of course. So now, thank you very much for your attention for this theory part. Now we will change. Alex is now starting his part with the case reports. I think, here it is. And then after this, he will show you a live treatment at the end of his case reports, and then you see me again with some case reports and another live treatment. And yeah, it was a pleasure. Have fun.
So, hello everybody from my side. Welcome to my practice. I hope you can see a bit short impression in the back. Yeah, I will start with some case reports, mainly cases out of professional sports, but also you can also transfer them into your daily active in your practice or clinic where you work. First thing was a Serbian soccer player, 31-year-old German Bundesliga player. The player comes in our medical staff room directly before warming up to the match. Declares that he is not able to play because he has some pain problems in his lower leg. He shows us a very hardened gastrocnemius muscle, right-sided, with some painful knots. He had this before, also during the week, frequently, but not at all this painful. We did an ultrasound, didn't see any injuries, palpable or massive string-like muculosis in a small part of the right medial gastrocnemius muscle. Standing on tiptoe, right side is painful and a bit less of strength. We couldn't palpable gap or punctual pain. Immediate therapy before the warming up was radial shockwave. Pressure was really high, 3 bar to 3.5 bar, which is also an indication in the beginning that there's no real big structural injury. We used the big applicator, as you can see, 36 millimeters. This was the older radial device. Meanwhile, we can use 40 millimeters. Frequency also 20 hertz. Now we use 25 hertz. And a high number of impulses. The result was it was immediately a lot better after the treatment. After warming up, we did another 1,500 impulses again in the same area, and he could play the whole 96 minutes included overtime in a very intensive match without any problems, and finally with a good result for our team. Pictures to the treatment, as you can see. This is the way we treat the muscles. Also very close with our hands on the tissue, to feel if we get any reactions. Another one of my favorite injuries, because I have a very lot of them. Just got another one today. Is the fracture and special Jones fractures, because the healing rate of Jones fractures are really bad. This was under 19 national team soccer player, offensive midfield, suffering from a distortion in the ankle, right middle foot. The X-ray did the surgery, as you can see the dates if you're interested, but I will make a summary of how long it took. Reposition with minimal invasive screw. This is quite important. We try to make the surgery just with a screw, not with a metal plate, because treating with a shockwave after surgery is more difficult if we have a metal plate around. With a screw, it's much easier because we can reach all the fractured area from all sides. The therapy after surgery was as followed. On day one, he was still in hospital. We're using different kinds of cold compression devices and lymphatic treatments. On day 2 and 3, we started with radial shockwave just for lymphatic drainage. With the big applicator, you can see the pressure and frequency below, and approximately 3,000 impulses. Afterwards, we always use some kind of cooling devices, cool compression devices. After day 2 and 3, we started daily with radial shockwave therapy, full contact on the fracture with a big applicator, always in the pain threshold of the patient. From day 11 on, we used the radial shockwave big applicator, and also starting with a 50 millimeter applicator going directly on the fractured area. No concerns about doing anything to the screw. The good thing is these players get well very, very quick without any pain, no swelling, and feeling really good. So you get confronted with another big problem. Players always want to play, want to recover very fast, so they get on your nerves and try to get some more time and start earlier. So what we did after 4 weeks, we did a control X-ray, as you can see on the left 2 pictures. You can see that the fracture is starting to heal. That is one of the most important signs we need for these kind of fractures. So we allowed air walker with a full body weight on the foot and start cycling without air walker, but with sneakers, with a good base to start cycling. On the right side, you can see the X-ray pictures after 6 weeks. Yeah, we're not expecting any callus around the fracture, but we can see a good bone healing in between. So we allowed the player start training with the ball, increase his running. Yeah? Follow up, the player started the team training after 11 weeks because he was suffering from a patella tendinopathy on the other side during the training. So this is just what we needed to treat in between with the Shockwave. And then he started directly with the first season game after 13 weeks in total. We tried to use the Shockwave in between for the next 6 months, just to fix the perfect result during the whole healing time and the refiguration of the bone structure. Then we had another one. Yeah, this was one of the second Jones fractures. We treated the same way. I made a little follow-up for you to see. We have special dates we use: return to activity, return to sport, and return to competition. And in total, it doesn't really mean it's important when a player starts cycling or running. As you can see, both Jones fractures recover almost in the same time. On this slide, you can see that return to activity and return to sport timetables really differ a bit from each other, but in total reach a daytime between 72 and 77, which is quite all right. We have no refractures in all of these Jones fractures treated by radial shockwave, and all fractures really healed very well. In comparison, we have some different, which you can find in the internet. Just took out another Jones fracture from a famous football player everybody should know, which took just a bit longer. Also, he's using the same shockwave device as we do. Probably has something to do with the frequency of treating. Another famous football player from Germany suffering from a Jones fracture, a refracture, and had a real horrible time not playing from 289 days. So I think the time rate we have with treating Jones fractures and all fractures with the radial shockwave from the beginning and no refractions is a quite good thing. Quite interesting topic on the next slides we have. This is a professional tennis player, 18 years of age, which had pain in the inferior ramus of the pubis. You can see on these pictures. Training has been impossible for 7 weeks. Junior tournament in Wimbledon cut short. US Open also cancelled as a precaution. The MRI showed serious left-sided osteitis pubis and symphysitis with the following results after 7 weeks of rest. 7 weeks of unchanged findings of an intense osteitis pubis on the left side with possible infraction near the symphysis pubis on the left side, which was the assessment in the beginning. The progression was the following. Pain has become even more pronounced over the past 7 weeks, even during the normal activities and without sport. As yet, only physiotherapy, pain medication, cooling things, ultrasound therapy, osteopathy, and all these things, which I think basic treatment. The osteopath involved us, then Peter and me, for treating this player, because she just said it's impossible to do it on her own. We started immediately with the following therapy: radial shockwave on the pubic bone, on the abductors, the entire back. First treatment was just possible with 1.3 bar every 3 days, and physiotherapy every 2 days, and gentle chirotherapy, thoracic spine, lumbar spine, sacroiliac joint, all these things. Initially, a high energy laser and a medical cooling device were also used for rapid reduction in pain during cold therapy. This was in addition to additional physio key in the area of the lumbar spine and the abductors. The result, sometimes later, 21st of September, was 90 minutes playing tennis training, was completely pain-free. The last shockwave, radial shockwave, was already with a pressure of 3.6 bar on the pubic bone and the abductors. If you see the checkup MRI after 8 weeks of treatment, you see the assessment compared to the previous examination: regressed spongiosal edema of the ramus superior of the inferior ossis pubis on the left as an expression of osteitis. Today, for the first time, a sign of secondary cleft on the left anterior lower edge, indicating a structural injury on the origin of the left abductor longus muscle at the transition of the aponeurosis. 2 weeks later, he earned his first world ranking point in the men's ATP Challenger tournament. We continued the further treatment, orthopedic insoles, lots of stabilizing muscle training and osteopathy for pelvic and lower back. No problems until today. He's coming for treatment in regularly timetables during different kinds of tournaments he's playing, and is not suffering from the same problems since 4 years now, and collecting nice points. Medial collateral ligament rupture of the left knee and left tractus iliotibial syndrome. This is a 32-year-old second league ice hockey goalkeeper from a German ice hockey club. At the end of 2020, so a quite new case. Yeah, he was suffering from a partial rupture of the left medial collateral ligament while playing. Yeah, and decided to make a conservative treatment. 2 months later, so on the 22nd of February, he was suffering from a complete rupture of the medial collateral ligament according to MRI following minor exertion in training. Since then, pain and instability, worries about the future, surgery already planned. We started the treatment 6 weeks later on the 7th of April with radial shockwave on the entire medial collateral ligament area of the left knee. From the second treatment, the left tractus and myoglossus were also included. Treatment every 3 to 5 days, 8 times in 3 weeks, then once a week. Strength and stability training restarted on the 20th of April after 5 treatments. Following progress, we had in 2 weeks later, middle of May, no complaints during any exercises with the physio. From the start of June, entire training load required of goalkeepers in the sports, no issues. On my birthday, 9th of September, abductor strain, MFR on the right during pre-game, severe myoglossus, more shockwave. Yeah, another 2 weeks later, start of the season, patient was completely pain-free, back to work as first goalkeeper of the team. And most important for the player, no surgery and nice future. Now we have a German football player suffering from acute ATFL rupture. Age 26, first league Germany, ankle distortion during a season game, ultrasound, complete ATFL rupture, massive joint swelling, consequential injury of the joint capsule, acute treatment within 1 hour, high power laser, and cooling therapy. We use in our practice different kinds of cooling devices, hyperbaric CO2 cooling device, game ready cooling bandages, special ones. You will see one of these things later, the bandages we need for our live patient. After 12 hours, we start with laser and radial shockwave, starting low, 1.5 bar, frequency almost as high as possible, 5,000 impulses, and the cooling devices I already mentioned. After 24 hours, walking with full load was possible. No swelling anymore. The MRI after 1.5 days. We did it all just there because we need some time to get an appointment. We saw the complete ATFL rupture as we expected. Only a very slight swelling of the joint, which is because we treated so early. This is the way we treat these ligament ruptures of the ankle with additional things. So of course the daily radial shockwave up to 3.0 bar, cooling devices, omega-3, Opensym, vitamin D, K2, stability exercises, and all this stuff are very important. Yeah, also manual therapy on the hip area. Of course, this is what we need to do. Yeah, really important. Return to competition was after 19 days. This depends on the. Basically, this depends how fast treatment starts. Yeah, best thing what I often try to tell my players is start treating on the pitch. If you have a teammate who is suffering from one of these injuries, go to him and try to make compression on the ankle. I would say the first 2 to 5 minutes are the most important, because as more fluid you have in the ankle, swelling you have around, it takes more time. That's for sure. I need to look if our live patient is already there. I would say Peter starting with his. I collect our live patients, and then I'm gonna show you if everything is prepared. The patient, I just want to tell you the background of this patient. He's a young sports student suffering from one of these distortions. He jumped off the horizontal bar. When he did the exit jump, he slipped around. Came to me 2 days ago. So we didn't do an MRI so far. X-ray was no sign of a fracture. We had the first initial treatment wasn't done by us, so he just came to our practice. We had a real intense swelling, a lot of blood in the ankle. The guessing what the problem is at least 1.5 to 2 ligament rupture. This will be the second treatment with a radial shockwave today, so you can be happy to see this in a few minutes. I turn over to Peter. He will start with another case, and I try to find our patients. See you later.
So, okay, now I'm back and try to fill the gap until the patient comes. We are a little bit faster than we thought, but this is good for the end, for the discussion. Now, I start with some more case reports from common practice. It's not only for sportsmen, as you had now with Alex, but I think also very interesting. One for me very important indication is the frozen shoulder, because this is something that people are really suffering from. As you can see here, this is an example. Lady, she's head of a children's home. She's mother of 2 children, and in May 2017 she had an overuse of her shoulder when she was doing very hard gardening work with her husband, and after that she became very bad pain, and she got very bad pain in her shoulder. The pain didn't resist even when she took NSAIDs, and then she got restricted movement and went to a colleague of mine. The colleagues first tried to do it with cortisone injections, I'm not a fan of cortisone injections in case of frozen shoulders because this kind of capsulitis, I think, doesn't work with cortisone. And here it was the same. Then she got oral cortisone until she had more than 10 kilograms more on her body weight. She got various painkillers up to morphine painkillers, and didn't work at all. And physiotherapy didn't have any influence on the movement. So when she got an MRI in August, we had these findings: clear capsulitis and the peritendinitis and the bursitis on the supraspinatus tendon. It was really horrible for her because then in October, when I saw her the first time, she had a maximum abduction of 10 to 15 degrees. This is really unbelievable because you cannot change your clothes. She had to ask her children to help her to change her clothes. Okay, then what did we do? Of course, we started immediately shockwave therapy. 1.5 bar is when you use the radial shockwave devices, not so much in for a shoulder. So you see the pain was really bad, but she had an improvement during the first session. I wrote the question before when somebody of you asked if you always have to have pain in the treated area. Normally you always have, or it's better to have a little pain so that you can see if it works like you want it to work, and that the patients can understand, okay, now it gets a little bit better. And what we predict them that it gets better during the treatment is very good for, I would say, very good for taking the anxious away. The people are very anxious when they have indications like this or diagnosis like this, and if they get the pain during the therapy, they are frightened that it doesn't get away. And then when the improvement comes and they say now the pain is going away, it's what you told them before, and it's easier for them to go on with the therapy. And in addition, we did cooling therapy, of course. We take the hyperbaric CO2, as you saw before in the picture of Alex with the ankle. We take cooling bandages and enzymes and so on. That's very important that we don't take only one therapy. We use more, but the most important, of course, is in this case the radial shockwave. After 5 treatments, we had 2.5 bar, very great improvement in pain. It got better and better. The patient was able to sleep again after a month of not more than 2 hours sleeping in the night. She could sleep the whole night without pain. And after 8 weeks of treatment, we had an abduction of 120 degrees. We started with 10 to 15, you remember, and then we had 120 degrees, and everyday life was possible without any trouble. And we did then even more physiotherapy, and the treatments with shockwave went in a frequency to 1 or 4 weeks, every 4 weeks. And we didn't have the necessity to take cooling bandages again. She was in a normal life and without pain, and that's what she has today. Years after this, we are still entirely symptom-free, which is for me really a great result in such a severe diagnosis like frozen shoulder. And what I want to show you before we have our live patient with Alex is that this is also proven in a study, the efficiency of radial shockwave therapy in shoulder adhesive capsulitis. I think this is for you very important that you can tell the people, okay, there's a study that shows that it is really, really significant results in using it for frozen shoulder. This is just, if you want to take this to show to your patients, I think this is very good for everybody. Now we have our live patient. Hi. Hi. Try to, yeah, wait, I have to take the camera and bring the guys into a better light. Okay. Komm mal rüber. Okay.
Peter, do you think we can remove your presentation so we have a better visibility of how is
Of course.
The treatment? Thank you.
Sorry, that's something I always forget. Like this.
No problem.
Do you see it?
No, I still can see your presentation.
What?
Perfect. Now we see.
Okay.
So as you can see, it's already a bit better. Yeah, see the blood strain in the area, the swelling from the bandage. Yeah, it's green. Yeah, everywhere.
Okay, we can even go closer. Here it is. Can see how blue it is here.
So we start with a frequency of 25 Hertz. Using the maximum of impulses for the beginning, and start with a low pressure rate. Using the 40 millimeter applicator. First, we start treating the swelling, yeah, and then we already go on the spot of the expected ruptured ligaments in the ankle side outside. Geht mehr? Geht immer noch? Geht da? Okay.
Abfallen lassen? Ja, lassen wir aber dann. Funktionsstellung behandeln. Schmerzen? Okay, von dem? Hier. Ja. 6, 7. Aufzuhalten. Ja, auch. Machen wir kurz Pause. Just a short break. What you can see is that Alex is always talking to his patient. He's increasing the load as fast as possible. Now we are, as you can see here, at 1.9 bar. We started, as you saw, with 1.2 bar. And I think you can also see that the swelling is going away while he is treating. And this is extraordinary, I think, and this is only possible with the Shockwave. Right.
Yes. Okay.
Right here. And see, there was the question, what kind of head means applicator? Which kind of applicator he's using? This is the 40 millimeter applicator of the new DolorClast device. I'll show you again. We normally always start, especially in acute injuries, we start with the big one because it is not so painful than the other ones, of course. You could also use the 20 millimeter applicator. In this case, I think I'll show you here. This is the 20 millimeter, and we have some other applicators for scars, for example, for deeper tissue and so on. Very, very good devices too, but in this case, the biggest one with the 40 millimeter is the best to get most of the edema away in the fastest way that's possible. Okay.
And the end was 2.0 bar maximum frequency, and in total we had 7,000 impulses on the foot. Yeah. In normal treatments, I would do another 7,000. Yeah, it's just to show you how we treat acute ATFL ruptures. Now it gets the, as said before, the cooling bandage around the foot. Yeah, the brace will stay down in this period for the next 3 hours. And then we have another appointment. When comes to here? Next 5 days. Next week. We will continue next week. Sure.
Okay. So this was all. Yeah.
Just one question from my side. So when Alex was doing the treatment, you do the treatment, the shockwave treatment along the tibial, the last part of the tibial. Okay. Side.
Yeah, you have to go a long way up because you want to get the edema away, and it's like if you do the lymph drainage, it's nearly the same. They always go up to a point that's normally, if it is more swelling than this, in this case, the first treatment was good, I think, because the swelling was not so bad. If the swelling gets higher, then we sometimes go with the knee, or maybe special in fractures, when we go higher up to the stomach, for example. Yeah.
Okay. So it's to optimize the treatment and the results.
Yes, to get the swelling away faster because of a better lymph drainage. And as you see in this case, the lymph drainage is unbelievable that you do with shockwave device. You can see it immediately when you work on the foot. That's really good. And we're doing so much lymph drainage after surgery or after fractures, or it's unbelievable. Or in acute situations that are much more horrible than this one, and it works very, very fast. Okay. So now we go back to the presentation. Vilket modifierar vi? Hey, technical part is his part. Perfect. Yeah. Okay. This was the case before. Does anybody have, MC, did you have more questions on the live treatment? Should we do them now, or can we just go on?
We have no questions for the moment.
Okay,
but,
then I think we go on. Everybody can note down what he wants to ask us later. It's no problem.
Quick question, just quick question from me. Another question. What is the mode? What is the mode that you prefer using between analgesic, burst, and ramp-up? Do you have a preference, or is it depending on the treatment?
No, that depends on what you treat, really.
Okay.
It's not depending on what I like best, but it's really, if you have someone who's very, very painful, try the analgesic mode. If you are not sure if the highest frequency is the best, try the burst mode. And if you are sure that you can increase the load very fast, the pressure very fast, then try the ramp up mode because it's easier for you. And if you have some, for example, professional football player or professional sportsman with muscle problems, sometimes the ramp up 2 mode going up to 4.0 bar is absolutely possible. So you really save time and it goes up without doing anything to it. That's really good, but it depends really on the situation.
And does it depend also on the tolerance of pain from the patient, or?
Yes, of course, because we normally work with pain that is really standable. I don't want to work with a patient who is crying because of the pain. That doesn't make any sense. But we need the pain, and we need the speech with the patient to get our information that we need. Sometimes you get the information from the reaction, from the tissue, and you need also the information that the patient can give you. And pain is talking about the pain is the best information that you can have.
Definitely. Yeah. Thank you.
Okay. I think we go on because then we can do the second live treatment after the next upcoming cases. One case that I always want to show is for me, very important case because it's about wound healing in a terrible case. This is a friend of mine. A few years ago, he fell from a ladder from a height of 2 meters. He landed on his feet. He didn't have any fracture, but there was a piece of metal standing out of the ladder and cut his thigh. You see, this is the right thigh in the middle. Cut it in the middle, and it cuts nearly everything, including the skin, the fatty tissue, the fascia, and the muscle. And he was really, really very lucky because he had 2 millimeters to the vessels. This could be his end. So he was very lucky. And this is a picture right before the operation at the hospital in Augsburg here. But then, and he was operated by Professor Meyer. Is a famous surgeon here in Augsburg. He is really, really good, and I think he did a very good job. But after that, he got an infection in the tissue, as you can see here. And the next slide is the most impressive one, I think. And of course, after this development, it was clear that you have to do something. You cannot leave it like this. If you see the red bandage around it, the guy would be really in a bad situation if he don't do anything now. So the clinic said that our mode of action would be: we debride the wound, we leave it open, we rinse it daily, and wait until the infection goes out of and the bacteria goes out of the wound. If the progress is good, after a few weeks, we can do a muscle flap transposition. Then after that, another surgery for a skin graft. And the total healing time that they said is 6 to 12 months. And I have to mention that he is extremely sporty. He's a marathon runner. He still plays very well football in a league here in Germany. And so it was, for him, it was terrible. He came crying and said, "Is this the way I have to do it?" Because he was frightened of having a problem with the muscle afterwards, and so with doing his sport anymore. And I said, okay, we have a very good situation for us for our try to do it with Shockwave and another, and of course, antibiotics and so on, but with conservative treatment options, because the surgeon said, whenever you come to my hospital with this again, I will operate you immediately, but you can tell me what you want to do. So we had the insurance that when we have no good result after a few days, we can send him to hospital and they do the operation right away. So that's why we said, okay, let's start a try with conservative therapy. And for me, in this case, it's Shockwave. After 10 treatments of Shockwave and 2 necrosectomies, I had to put away the necrotic tissue after the first Shockwave treatment and after the third Shockwave treatment, because the growth factors and so on work so strongly in the wound that they bring up the necrotic tissue, and then you have to cut it away, of course, because it would be in the way of the healing process. And now I want to show you a video. It is in German, it doesn't matter. I just want to, and I shorted a little bit, but I just want to show you how the tissue developed, how the wound developed, and what kind of, and when you see this, the guy is running again 7 to 8 kilometers in the week before. After 7 weeks he started without any problems. So have a look at the muscle and how the tissue, how soft the tissue is, and how good the movement of the muscle is. Okay. What I wanted to say again is, you see that we really work on the tissues with pressure too. This is really to get a feeling for the tissue. I didn't start with such pressure on the tissue at the beginning, of course, and you have to be very sensible for the patient, of course, but afterwards, if it works like this and the scar is so stable as you saw it here, and the tissue is so soft, the muscle is so good, then you can really work with a lot of pressure on it. That's why we always, if you have a sportsman with muscle injuries, we work with a lot of pressure with our hand and a lot of pressure from the Shockwave device. One of my favorites is polyarthritis of the hands, because this is really something the patients are suffering from. It is completely bad for their life quality. Sometimes they say they don't have any more life quality because they cannot use their hands. They cannot do everyday things from everyday's life, because nothing is easy anymore if you can't use your hands properly. And if you see this patient, for example, she was suffering really bad. She couldn't do the normal things in her life anymore, and now she's smiling here because this is the 3rd or 4th treatment, I think, and it gets much better, and very fast. It gets much better if you work with these hands, with Shockwave on these hands. We do always the same. We use the big applicator because they stand it much better. We normally use 3,000 to 5,500, 4,500 impulses per hand. At the beginning, maybe 7,000 per hand. That's possible. First, we use it on the joints. Then we do a little drainage, always from distal to proximal. And the first treatment is, sometimes it's, in this case, it was 0.8 bar. In other cases, we can start with 1.0 bar. If you use the high power laser from GDT before, then sometimes you can even start with 1.5 or 2.0 bar. It depends on if you have the high power laser as the possibility to use before, and it depends on the patient and on the applicator you use. In this case, we started with 0.8 bar. The second treatment was already possible with 1.6 bar, and after the third treatment, she didn't take any more pain medication. That's why she's laughing on the picture. The mobility got better, and after 5 treatments, she was entirely pain-free. She could do gardening work again, and we could keep this result in using it every 8 weeks. So 1 treatment every 8 weeks means, of course, 6 treatments per year, and she's still entirely pain-free. And the swelling went away. She could wear her ring again that she had to keep off for 10 years. This is also for me very important because I can show you a very young patient. This is a 15-year-old track and field athlete, very good athlete, one of the top athletes in southern Germany in his age. He had a shooting pain during doing hurdles in a competition 1 week ago, and he described it as where it was located at the pelvis above the left hip. So we did an ultrasound, and we could see an intramuscular hematoma of the tensor fasciolate. This is not a very common injury for sportsmen, but when you do athletics like hurdles, this is a special kind of muscle contraction that you have in this area. So and it is very, very painful. It means in this case he had a visual analog scale from 8 to 9. He couldn't really walk properly, and he had the same too with his shin splints. So he had 2 problems, one acute and one the shin splint problem was always rising during a competition, and after competition he had also a visual analog scale of 8 to 9 from both shin splints. And this he was suffering from this the last 2 years. So we had to work with him on 2 things: the acute muscle problem, which was really bad, you couldn't even touch him. And after we only could work with 1.4 bar on the first treatment on this muscle, which is for this muscle really too little. Then we used also the cooling, of course, because it was acute, and we used the Shockwave for the shin splints. Here it was 0.4, but we had to use the older device at the beginning, 0.4 and 0.6 bar on the both shin splints. And the second treatment was much better. We could use 2.5 bar on the tensor fasciolate muscle, and we could start with a new device with 1.1 bar on the left and 1.2 bar on the right side of the shin splints, which was a great result after 1 treatment. And the third treatment was he was feeling much better when he came for the third treatment, and he was starting light training again. It was successful. He had 2.7 bar on the muscle and 1.4 bar on both sides of his shins. For the first time in 2 years, he had no pain there. That was very impressive for me because he's a young guy, and he was really suffering. And after 3 treatments, we got away the pain that he couldn't get away for the last 2 years. And he went back to full training, and the result was that a few days later there was the U16 or under 16 Bavarian Championships. He's 15, so this was all the other guys were 1 year older than he was, and he took in 2 competitions. He took the first place, and in 1 competition the second place. And it was even wrote about him in the newspaper, in the local newspaper. That was really for us a great result, and for him very successful. Okay. Now we are looking for our second live model. I will tell you the story about her. Claudia is a patient for the last, I think now 16 years, because I know her very, very early in the children's hospital. When she started her, I would say, bad career with her chronic osteomyelitis when she was 11 years old. Hi. And I will show you the whole story, but first of all, little applause. Claudia began with her problems at the age of 11 when she got a distortion, a simple distortion of her right upper ankle. Then after that, an osteomyelitis developed with severe osteonecrosis zones, and she had 9 times, now 10 times surgery in total. 11 times surgery in total with this ankle, and as you can see, there are zones of necrosis, bone marrow edema, and I show you some more pictures. You see a bad bone marrow edema, which is, everybody knows that, very painful. You see problems with the cartilage, with the whole ankle, that the joint has not the normal form that it should have, and that's her career in pictures. It's always the left foot. It's always swollen the whole time during her when she was coming up from age, and even now you see the scars and you see the swelling. Then we had in 2016 the problem that the pain increased more and more. She was not able to step on her foot again, and she had a very bad MRI, as you can see here. New inflammatory process, which means the osteomyelitis was again in a very bad stage. Then she had a complete immobilization for weeks, and after 7 or 8 weeks of immobilization, we had newly bone marrow edemas, and we had newly demarcations of the cartilage and necrosis zones, so no improvement at all. And that was the time when she was really at her in a depression at her end, really, because the now suggested possibilities of 5 foot surgeons, specialized foot surgeons in Germany, was on the one hand stiffening the ankle or an amputation of the lower left leg. And she was in a mood that she said, okay, when the pain is going away with this, then I will do the amputation, because the stiffening of the ankle would only bring the problem to the next years, and after that she would have the problem that the next step, the amputation, would have been done. And she said, then okay, then let's do the amputation. That was the time when I said, no, give me one more chance. And the last chance was to get all the stuff away out of her ankle, like the cartilage parts and the swelling, the capsule inflammation, and we wanted to get this away with one more arthroscopy with a very, very good surgeon in Munich. He said, okay, we can do that, but I don't know how to do the post-operative treatment, because in this case I have no idea how he can help you after the operation. And that was possible, perfect, because I said, okay, then you do the surgery and I go on with the Shockwaves therapy, because I want to get the inflammation out of the bone, I want to get the inflammation out of the capsule, and I want to give her some growth factors into this part to get a better result than after the first 10 operations, because in this, then we started after 4 days after the operation, and the result was that we could get her pain away significantly faster than normally. The swelling was much better after 2 weeks. We did have this result in all the 10 surgeries before. The mobility improved every week, and she could do more stabilization and put more weight on it earlier than all the operations before. And after 4 months, we got this MRI. I show you, and I think everybody can see how much this ankle improved. Let me go back to this one, and especially this one, where you can see the bone marrow edema and the necrosis zones. And now we had this result, and she was, from then on, she was most of the time nearly pain-free. We are still working on the ankle every 8 to 10 weeks, but it's much better, much better than before. And she's, of course, not thinking about one more operation or stiffening or even amputation. And as you can see, she can smile again. This was from 2018, and the newest one, when she did a trip to Iceland, her favorite country, where she couldn't go the years before. You see, she was walking a lot there, but the foot is not so painful that she had to quit. It's a great result, and now we want to show you how we work on her ankle normally. It's the same with the osteochondrosis dissecans. It's the same with all kinds of arthrosis in the ankle. So this is for all your patients suffering from this. And she has got a problem with her biceps at the right shoulder. Yeah, at the right shoulder. It's a tendinitis of the biceps. It's a capsulitis that she's suffering from at the moment, but it's getting better now. And she had a ganglion that was operated because it was exactly at the biceps tendon. And we'll show you how we work on the shoulder. Ja.
Can you see us?
Yes, I can see. I can see. Yeah, we can see.
I just correct the setting. Okay.
Sometimes the image is cutting, but I think it's linked to the connection or.
Do you see us?
Yes, I can see the beautiful leg from Claudia. Perfect.
I see. The leg has no big swelling at the moment. It's a little bit more than normally that we have now, but for the story I told you, I think it looks pretty well. So you look always pretty well, but you know. Okay, then we start. I always start at the ventral part. I go into the ankle. We go. Sorry. Geht noch. Sehr gut. In this case, or all kinds of arthrosis in the ankle, we go we try to reach it from every direction, because we can go deep about 4.5 to 5 centimeters. So if you use it ventral and from the lateral side and from the medial side, where it can get into the tissue very easily, I think you hit the talus and the tibia in every direction, and that's normally exactly what you need. You have to get so much energy inside as you can. In this case, she stands 2.0 bar after a little chiropractic. I think we can even put some more on it. Jetzt geht's mal wieder. So this is also very important. If you see that the joint is not in the right position a little bit, so you can do some chiropractic, put it back into the position you want, and then use the Shockwave device again and see how much you can improve. You can increase with the working pressure. In this case, from 2.0 to 2.5. I think even 2.7 would be possible, but it's not necessary now because now she's pain-free and the moving is better than it was before, and that's what we want here. Okay, good. We go to the shoulder. Ja, ganz besser. Jetzt.
Ja, geht, klar. Da habe ich kein Problem mit.
Ja. Oh, ganz klein. Ja. So she has 2 little scars because the ganglion was set it here, and she had the operation.
July.
Okay.
July last year.
About 6 months ago. Now it is much better because the ganglion is not there anymore, but she's suffering from this tendinitis now. It didn't come directly after the surgery because we did a lot of shockwave, then it was gone, and now it comes back a little bit, but it is good to show how we work on the shoulder. So first of all, in this case, I work on the part where the ganglion was and the tendinitis of the biceps, and then we go to the whole shoulder, do the supraspinatus tendon, and have a look at the capsule. position of picture.
Yeah.
Let's see. This was just to check if there's a problem with the pectoralis muscle, because sometimes when especially after surgery, when the shoulder comes a little bit too ventral in the position, you have the problem that you have a hardening of the pectoralis, which brings it in the shoulder in a bad position. And if you make it, you open it here, like relaxing, then the shoulder comes back and you can treat all the other things in the shoulder in a much better way. So now let's get to the back. Wer kann sich bewegen? Frage? Here you can reach all the most important parts, the biceps tendon, supraspinatus, infraspinatus. We always go here into the neck. That's what I show you next. And we always work on the AC joint just to see if there is a problem too.
Ja. Ja.
Versuchen wir gerade nicht. Weil da kommt die Knoten.
Mhm.
We don't go into detail because this is another to work on the back is another part. But always, if you're working on the shoulder, please do at least the trapezius muscle and a little bit of the shoulder bladder or put it into your treatment, because the hardening here makes the position of the shoulder really bad, and that's the problem. If you don't get them out of the bad position, the tension on the tendons is so bad that it gets worse and worse. Okay? Okay. Yeah. Okay. We have a gel problem. Okay. So. Okay.
Thanks, Peter, for showing this treatment.
Yeah, time is short. I know was a little bit long, but we didn't expect to have 2 live treatments. It was, yeah.
That's okay. That's
Well,
okay.
it depends where you take it.
I'm sure people enjoyed it. We have a quick question from a participant, but not medically, not a medical question, but more a billing question. Do you charge typically? Do you charge typically per visit for shockwave treatment, or do you charge as a package, including a few treatment shockwave sessions?
We don't give them like a I would say a 10 treatment pass or something. We don't do this because and we don't charge every visit. We tell them, okay, we think we need 3, 4, 5, or even 7 or 10 treatments, and after about 3 to 5 treatments, they get normally the first from us the first bill, because that's what over the last 2 or 3 years was our what I had mostly with the patients, that they said, okay, please give me a bill after 3 to 5 treatments, because then I can see how much it is for me and so on. And I think this is the best, to do 3 or 4 treatments, see if it gets better, and then give them the first bill and let them pay for the first part, and then see how it goes.
Okay. It depends also how the body reacts to the shockwave treatment.
Yeah.
And yeah. Okay. Thanks.
I see the next one. Very good question, because you can see it a little bit on the picture we had. We only use the volar side, not the dorsal side. Sometimes, yeah, I know he's a bit different in this. He sometimes does the dorsal side, but this is because he's the bad guy and I'm the good guy. I'm only doing it there where it is not so painful, and he's also working on the dorsal side. But it doesn't. If you put enough impulses on the volar side, it's okay, because you easily get through the whole tissue. But he always wants to, yeah,
Be hard.
have more fun with treating the patient.
Okay, thank you. And talking about hands, is it the same protocol for how do you call it, palmar fibromatosis? Is it the same protocol as polyarthritis?
Yeah, you can do exactly the same. The problem with the fibromatosis is it depends on the stage that the patient reached before. If you have a real problem like this, they also call it Dupuytren contraction. The problem is how strong the contraction in the hand is. If it is really bad, you can only tell them that the pain gets better, but you will not have influence on the tissue. If you start earlier, I think you can have good influence on the tissue. It's the same with scars. You always get scars better, but if you start early treating the scars, it's better than when they get like a keloid and they're older. Yeah.
The earlier, the better. Always.
Yeah.
Okay.
we always treat nearly exactly the same, as we look the same, so we treat the same. The only one that we do it different was the hand and the question before.
Okay, thank you. Any additional questions?
After 2 hours, they are all
Please
tired.
don't be shy. Take advantage of these 2 great experts online. If you have any questions. Everything, every question is
not about the hair.
No issue there. No.
At our football club here, they call us cone heads, so that's why.
No more questions.
Oh, okay.
Good.
You can tell everybody if the question comes up later.
Text us.
Text us.
Yeah, is shockwave therapy the reason why you look like?
We look like the applicator.
We don't know. We are the only 2 guys who make 225 million shots a year. So yeah, probably, yeah. Who knows?
Maybe.
But if the question is coming, my ears are working. Yeah, I hear everything.
But if the hair problem is the problem of the shockwave, we can go to EMS, I think. Okay, now.
I have a last question. If people don't have any question, maybe, well, I had a recent question concerning diabetes and problems with coagulation. Do you by chance have any patients suffering from diabetes and who have like coagulation issues? And do you, well, I know this is a tricky question because coagulation is one of the contraindications. So what is your opinion about this? Can we treat people with suffering from tendinitis and who suffer also from diabetes?
Yes, I think this is not really a problem because the diabetes has normally no influence. Sometimes it takes a bit longer because the healing process is not so fast, but normally you can use it exactly the same way, but you have to tell them that in diabetes, but it's all kind of immune deficiency. It works a little bit slower, but it works, of course. Okay. You have to, for example, the diabetic foot is a real problem because they normally don't close up the wounds, don't heal because of the diabetes, and we get them closed in nearly every case with shockwave. It depends on the blood flow, but normally if it's only the diabetes, we get the wound healing perfectly, and I think this is the best sign to show how it works even in this case.
Okay, thank you. Thank you for this response. I will let them know. Okay, I think yes, this was a very nice presentation. Thank you for sharing all these atypical cases with amazing results. Thank you, Peter. Thank you, Alex. I think you can close your FNA window because we don't see it anymore, Peter. And that's a shame for the end of the webinar. Thank you. There you go. So thank you. Thank you both for sharing your experience. Thank you for bringing these patients. Thank you, Claudia. Thank you for the others. And thank you, everyone, for participating. We will get back in the next months with other sessions on the various topics. So stay connected and consult regularly our Facebook page. Also consult regularly the Swiss DolorClast Academy website. We'll keep you informed. Take care, and thank you again, Peter and Alex, and see you next time online. Take care. Bye-bye.
Bye-bye.
Bye, everyone.